Welcome, everyone. Thank you for joining us for our free Healthy at Work webinar series. My name is John Beveridge. I'm the coordinator for Occupational Health and Safety at Windsor Regional Hospital and chair of the Working Toward Wellness Committee. Jeff McEwen, manager of Recreation Services at Clair College, will be moderating the webinar today. So now I would like to introduce our guest speaker, Dr. Jason Abrams. Dr. Abrams is the Associate Medical Director and a Senior Medical Consultant at the Medcan Clinic in Toronto. He is a graduate of the Schulich School of Medicine and Dentistry at Western University in Ontario, and he completed a residency in family medicine at McGill University. Over the years, he has completed locums in family medicine and emergency medicine in the Greater Toronto area, and has practiced in walk-in clinics in the community. Additionally, he has been an independent medical examiner for Section 44 assessments under the Statutory Accident Benefits Schedule and a low back expert physician examiner for the Workplace Safety and Insurance Board, known as WSIB, as part of an initiative to focus treatment and implement safe return to work for employees who have injured their backs. His professional interests include preventative medicine, occupational medicine, and virtual medicine. We thank you, Dr. Abrams, very much for speaking with us today on safely returning to work. I will now pass the virtual mic over to you.
Excellent. So, thank you so much for allowing me to speak to the group today. I'm excited to talk to you about the current state of affairs as it comes to the pandemic and how that relates to returning to office work for many corporations. The first topic we'll cover is to get an update about the current situation with the fourth wave in Ontario and talk about vaccines and efficacy. We'll look a little bit at predictions and modeling that's come out recently with regards to the fourth wave over the next couple of months. And then we will also talk about vaccine policies. And lastly, it doesn't seem to be listed here, but we'll talk about a more in detail approach to organizing yourselves for return to office for those who have already started to and for those who will be doing so in the coming months. So, the fourth wave is really the Delta wave because the Delta variant of COVID-19 virus called SARS-CoV-2 is the most prevalent strain of the virus that's in our community right now, by far. The Delta variant is significant because it's a variant of concern. You see, there's two types of variants that can arise, which are triggered through mutations in the COVID-19 virus that make it a little bit different than it originally was. Variants of interest are variants that are present and found in different areas of the world where the infectivity or the severity of disease is not necessarily changed significantly. But variants of concern arise when you have a variant of the virus that can be more infective or cause more severe illness. So when we compare, if you look on the right side of the graph here, when you compare the Delta strain to the original virus, you can see that the infographic shows if one person was infected with the original SARS-CoV-2 virus, they might actually transmit that to about 2 to 3 people. With the Delta variant, if somebody's infected with that variant of SARS-CoV-2, we see that that person can infect up to 6 to 8 people around them. So the transmissibility is significantly higher. In fact, almost twice as high as the original COVID-19 strain. And when we think about comparing different variants that have arisen, if we compare the Delta variant to the Alpha variant, which was the original variant strain that started to be found in the UK, it's 40 to 60 times more transmissible than the Alpha variant. So a lot more infective, a lot more transmissible. Statistics have also shown that hospitalization rates are about 2 to 3 times higher for those infected with the Delta variant as compared to those infected with the original SARS-CoV-2 virus. So more infective, more transmissible, and higher severity of illness. That's why this is a variant of concern rather than just a variant of interest. So how did the vaccines stack up against the Delta variant? I would like to put it out there and be completely transparent in saying that it is true that vaccines are not 100% effective against the Delta variant. If that is the expectation, we are setting the expectation wrong. In fact, there's no vaccine that's 100% effective against anything, pretty much, that I can think of in terms of major public health initiatives over the years, including a regular one such as the flu shot. It's not 100% effective. However, what is important to note is that the more people that get a vaccine within a community, the less likely we are to see spread through that community because of the reduced risk of any individual in that community of catching the infection and then passing it on to others. So, how effective are the vaccines against the current predominant strain, the Delta variant? There was a recent study that came out at the end of July in the New England Journal of Medicine, which showed a comparison of the efficacy of the AstraZeneca vaccine and the Pfizer vaccine with the efficacy of 1 or 2 doses of these vaccines. And please remember that they are both 2-dose vaccines to be fully vaccinated. So this highlights the reason why. And what they were looking at for efficacy was how effective are the vaccines at stopping somebody from getting a symptomatic COVID-19 infection. So with both the AstraZeneca and the Pfizer vaccine, 1 dose of the vaccine was about 30% effective at stopping symptomatic disease. Now, they start to differentiate from each other when we look at the full series with a 2nd dose of the vaccine. So if somebody has 2 doses of the AstraZeneca vaccine, it's about 67%. 2 out of 3 people will stop, the vaccine will be successful at stopping symptomatic disease. The Pfizer vaccine is significantly more effective with the 2nd dose, stopping 88% of symptomatic disease in a fully vaccinated individual with the Pfizer vaccine. Now, this study did not publish the other predominant vaccine in Canada, the Moderna vaccine, but we know based on other data that the Moderna statistics are actually very similar to the Pfizer ones. In fact, it's interesting because in Canada, there's been a little bit of a bad reputation amongst the general public for getting the Moderna vaccine, right? Everybody thought that the Pfizer vaccine was a little bit better. But against the Delta variant specifically, the Moderna data shows that it may even be a few percentage points higher with a fully vaccinated individual at stopping symptomatic disease of the Delta variant. So vaccines are still the most important barrier of defense that we have on a public health scale, as well as significantly so to the individual, because they reduce the risk of infection, and thereby they reduce the risk of transmission in community, more so with the more people that are vaccinated. They also reduce the risk of hospitalization from COVID infection. And lastly, they reduce the risk of death from COVID infection. So the mortality rates go down in somebody who's vaccinated. And if you think I'm just saying that, I'm going to show you a slide from the Ontario Science Advisory Table. This came out a couple of weeks ago, which highlights the effectiveness of vaccines in these scenarios. In the graph on the left, you can see the difference between a fully vaccinated and an unvaccinated individual. The unvaccinated person has a 6 times higher risk of acquiring a symptomatic COVID-19 infection. Even more significantly, the unvaccinated individual compared to a fully vaccinated individual has a 30 times higher risk of ending up in the hospital if they acquire a COVID-19 infection. And lastly, showing the disparity even further, there is a 48 times higher risk of ending up in the ICU with a COVID-19 infection if you catch the infection when you're unvaccinated versus if you catch the infection when you are fully vaccinated. Thereby, on an individual level, there's a significant benefit to becoming fully vaccinated because it reduces your risk of having serious consequences and makes it easier to recover from the infection. The Ontario Science Table recently released further predictions on the 4th wave. We were all waiting all summer to hear, well, what is the modeling showing? from Canada and Ontario about what to expect with the fourth wave. We all heard it was coming. So there were 5 teams at 5 different Ontario universities that built models using different approaches and assumptions. Each team runs multiple scenarios reflecting key factors like vaccination and contacts. The teams meet to review the models and determine the most likely scenarios to present. So they all agreed that this graph here reflects the possibilities for daily cases going forward through the months of September and October. The upper range, this red bar at the top of the graph here, shows a 25% increase in transmission. That is expected when we think about things like going back to work and going back to school and being back together more closely congregated in indoor spaces. In fact, if you look at the news from the last 24 hours, you guys are nearly a week into the kids being back at school for the fall. And in Toronto here, we're only 3 school days in, and already there's 189 reported school-related cases across Ontario. The lower range here reflects a 25% decrease in transmission. So that would be this green bar here at the bottom. And then if things continue to go the same as they are now, you see that there's going to be an upward tick in cases as we get into October. All of these models did take into account that we will see progress on vaccination, which we're nudging the public and we're encouraging everybody to get vaccinated who hasn't been yet. Pardon me. If we cannot reduce transmission, and the experts suggest that we need to reduce our contacts by about 30%, so to 70% of what they are now, to be able to not overwhelm our healthcare system again during the fourth wave. But if we cannot reduce our transmission from its current state and accelerate vaccination to help reduce transmission through the community, ICU occupancy in Ontario could exceed wave 3 by October. So there are about, with the processes put in place, they've increased the capacity in the ICUs to about 2,300 beds available. But we must understand that the more COVID beds that, the more ICU beds that are taken up by COVID patients who are trying to recover from their illness, we don't have space for things like post-surgical patients who need an ICU bed. So there's a downstream impact. And even last week, they came out with the stats to show that if somebody is in ICU due to COVID infection, the cost of that stay is 6 times greater than the cost of somebody being in an ICU for recovering from a heart attack, for example. So there's a huge burden on the system for people catching COVID and getting very ill, as well as, of course, the imminent danger to that individual. So one of the things that's developed is that we've seen a lot of organizations have instituted vaccine policies, and it behooves every employer to come up with a vaccine policy. On a government level, there is mandates for vaccines across various institutions, both federally and provincially. We've even seen the local public health units recommending employers institute a vaccine policy. The Ontario government said for essential workers that you would need to have your employees vaccinated unless they have medical exemptions. And if they're not vaccinated, then they would at least require to get regular rapid antigen testing if they're non-vaccinated, even up to multiple times per week to be able to continue to come into work. However, individual companies have actually adopted a more stringent policy in which they've stated that their employees must be vaccinated for them to come back to work. And for many people, for them to come back to work is necessary for them to continue then working in those organizations. In fact, I always look at this from a medical lens because that's my expertise, but the leading legal experts out there have suggested that it is perfectly okay to mandate a vaccine in your employee population because the public health risks trump the choices of the individual. I won't speak more on that part because I will leave that to legal experts, but we are seeing major organizations across North America and the world, and even particularly locally, we're seeing organizations that are mandating vaccines amongst their employee population. And you can see the example here of several local organizations in the Windsor area, including hospital, academic institutions, and even the city. According to the College of Physicians and Surgeons of Ontario, the CPSO, there are only 2 medical exemptions that employers should consider in which somebody may not be eligible for a vaccination and should be excused from this policy, or accommodations should be made. The first exemption fact is an allergist or immunologist confirms severe allergy or anaphylactic reaction to a previous dose of a COVID-19 vaccine or any of its components that cannot be mitigated otherwise. So for example, if somebody gets a low-grade fever after getting a vaccine, that's an accepted and expected potential side effect of the vaccine, which resolves on its own, can be treated symptomatically, and usually only lasts a few days. That would not be considered a confirmed severe allergy or anaphylactic reaction. What we are talking about is a life-threatening reaction that requires medication intervention, hospital intervention. And for example, one thing we see in the mRNA vaccines, including the Pfizer and Moderna vaccine, is that these are made with the compound called PEG, polyethylene glycol. So if somebody is known from a previous exposure that they're allergic, severely allergic or anaphylactic to PEG, they would need to connect with an allergist to confirm this allergy, and that would make them exempt from getting the COVID-19 vaccines that are currently available. The other exemption is a diagnosis of myocarditis or pericarditis after an initial dose of an mRNA vaccine. So, and this is particularly prevalent in the younger population, but if an individual suffers from one of these consequences after a first dose of a Pfizer or Moderna vaccine, it might be reasonable to put the second dose on hold medically. Right now, NACI, the National Advisory Committee on Immunization in Canada, is reviewing the data on myocarditis and pericarditis associated with mRNA vaccine administration, and they will come out with further information and further guidance on what to do in these cases about getting the full vaccination series with the second dose and potentially even third doses going forward. So if an individual is unaware about their current medical situation, they are urged to seek medical advice from their healthcare providers as soon as possible in order to be directed to the most appropriate intervention. We are getting lots of requests for vaccine exemptions for different reasons, but we have guidance in our profession now as to what is considered medically appropriate at this time. I first came across this in December 2020. You see, vaccines are one of many strategies that are now being instituted to try and reduce the risk of infection in public spaces, common spaces, indoor spaces, and we see this apply all across the board when we're starting to bring people back together in different spaces, whether it be public transportation or office buildings or retail centers or restaurants. Academic institutions as well. You see, what I really find effective about this slide is it highlights the key is that no one measure is 100% effective, but that's okay because if we layer different measures with each slice of Swiss cheese in this Swiss cheese model graphic representing a different measure, even though each layer has holes, it's likely that another layer will catch the virus particles that are trying to reach the individual when thinking about how somebody could acquire an infection. So all of these measures that are the same as the very beginning: keep physical distance, stay home if you have symptoms, using hand hygiene to wash and sanitize regularly, limit your time in crowded spaces, ensure adequate air filtration and ventilation, wearing masks, and even now it's becoming more prevalent and moving more to the left side of this infographic is the last slice of Swiss cheese here, which is the vaccines. And education of the public as to why these are all important. So when we think on a more pointed level about returning to office and preparation for returning to office, we think about taking a targeted approach to different factors. So one which we've talked about already is the concept of a vaccine policy. And every individual organization can consult with their HR teams and their legal counsel and medical experts to come up with an appropriate vaccine policy for their employee population. But it is important to have a vaccine policy and to make it clear and concise across the board, and a way to adjudicate decisions on an individual basis, because there will be exceptions to the rule. It is important to review the workspaces and communal areas to ensure that you can allow for physical distancing and to look at ventilation. It is important to utilize daily employee and guest symptom and contact screeners. So those screeners that many organizations have been using, before you enter this space, have you had any symptoms in the last 14 days that could represent a COVID infection? Have you had any close contacts with anybody diagnosed with a COVID infection? Have you been contacted by public health? Or have you been traveling in the last 14 days internationally? All of these things, having that as the front line for your employees when they're coming in, and even employing these electronically within your workplaces, can help reduce the risk of somebody coming in who's had a close contact or who has symptoms of a possible infection, and then creating contact tracing issues within your workplace. Instituting physical distancing and maximum capacities in common areas is very key. The basic tenets of reducing vaccine transmission still take place. And including in that is trying to keep at least 2 meters from people, as many opportunities as possible, whether it be in meeting rooms, in the employee kitchen, reducing capacity in communal bathrooms. All of these things can go a little bit of the way to help in that Swiss cheese model of using multiple layers to reduce the risk of transmission of infection. I like to call this mask etiquette expectations. So what are the expectations of people wearing masks in an indoor workplace? If somebody is working in an office behind a closed door and is sitting alone, it's probably appropriate for them to take off their mask during that time. But if they have a guest in their office, it should be the expectation that the etiquette is both people put on their mask when they're going to be sitting in a closed space. If somebody's working at a stall, such as the next one, the one in the slide here, and they're in close quarters and they're sharing the same airspace, it may be reasonable to have those people wearing a mask during their day. If they're sitting more than 6 feet apart, you can make the argument that they may be able to take their mask off at their desk or not. Different experts disagree or don't necessarily have 100% consensus on those. But if those people are moving around the office space or visiting their colleagues, it should be mask etiquette that people will put on their masks when they're coming into closer proximity, less than 6 feet space with other people. I think one key is we always learn from our own mistakes, and then we learn from the experiences of others. So I think as people are planning to integrate more people into their workplaces, I think it's important to learn from the examples and the lessons learned from the first people who are moving back into the office space in September. And then most importantly, it's important to be flexible, because what I'm telling you today may be different in 3 weeks from now, 6 weeks from now, 3 months from now. 1, because there will be a change in the vaccination rate. 2, because the science may change. 3, there may be a new variant of interest or variant of concern that's on the horizon that changes the circumstances. And 4 is the experience within your workplace and what's happening with your employee populations. So what are some of the best practices that we advise people to consider? We think it's important to provide clear rationale for describing and marking what is essential versus non-essential when it comes to work and employees. We think it's important to be flexible, as I mentioned in the previous slide, but it's also necessary to be consistent in applying return to work policies. As important as it is to come up with a policy, the governance over that policy and adjudication of individual cases, it's really important to keep that consistent across the board. It's important to clearly define terms for your organization. You know, what is a mandatory business meeting? What is a voluntary event? And what is considered social, so that people in your employee population will understand what's necessary for me to be at and what could I potentially, you know, log into from home, or something that's not necessary for me to be involved with. On the concept of being flexible, it's important to keep up to date with the changing trends in health risks. As we will see, there's going to be an ongoing roller coaster in the coming months of increasing and decreasing rates of transmission within communities. So it's important to be a quick follower of changing trends and to be adaptable to whatever is most relevant at any given point in time. And to communicate that we are going to be flexible because the situation may change. One of the biggest concerns going forward is not necessarily just the physical risks, but also the mental health aspect for employees who've been working from home for the past 18 months, who are going to be re-entering the workplace. It is really important for employees to consider providing mental health support for those in the greatest need, who are concerned, are anxious about coming back into the workplace, changing their exposures, and what may develop in terms of risk to themselves or their family going forward as a result. We know that there are many people who want to go back to work and who are asking to go back to work because of isolation where they live, and they want to communicate, they want to socialize with their colleagues, they want to change their routines. But we also have individuals who will be more hesitant to do so for varying reasons, and we have to be supportive and understanding of that and work through those cases and provide that support to those individuals. It's important to promote better communication across teams as well, because we may see cliques that develop based on the comfortability of individuals. You know, it's also a reason why it's important to have clear policies in place and to administrate them across the board. You know, you may see within your organization that there are a few people who keep to themselves, keep very physically distanced, and are wearing their masks all the time. And there may be a few people who like to congregate together because they're feeling a little bit less concerned than others about, you know, COVID-19 risks. And they may say, well, you know, the few of us, we're all okay taking off our masks, but it's important to have clear policies and be consistent about it so that everybody within the organization can feel comfortable. I like to think of it as planning for the, you know, the most anxious person who's coming into the office, that they should be feeling comfortable, even if that puts a little bit of extra burden to be a team player on those who are less inclined to take all those measures in their personal lives. They're working as part of a team, and this is part of being a team player. So within your corporate culture, it's important to walk the talk. The best way for employees to establish a culture of trust with HR as they come back to the workplace is if, you know, the management, the executive, and the HR team that are administrating the policies and implementing the policies are actually doing what they're suggesting should be done. It's going to be really important to train managers how to have difficult conversations with individuals. I find even with my own practice, even just asking the question about vaccines can be a very difficult discussion. And part of it is that, you know, your managers may know what the right idea is, especially when you have strong policies in place, but it may be difficult to have those conversations, and equipping them with the tools to do so will be very beneficial for your organization. We want to create a culture of acceptance and support, and to be able to listen to feedback from employees. We may not always implement what employees suggest, but it's important to be accepting of feedback and to work through it with them. And then it's always helpful to use a nudging approach to change behavior, using incentives where possible. When we consider the impact of the pandemic on employee health overall, and specifically with mental well-being, there's a few things to consider. We already talked about the second point here, the cliques that may develop at work due to workplace flexibility that varies between individuals, and the importance of enacting the policies that are created with all the hard work that everybody's done to create policies as we go back into the workplace. We know that the young workforce population who've just graduated from school and are getting their first jobs during the pandemic, many of them are very isolated, and they're excited to come back to work because they feel they have lower risks of severe disease if they get COVID, but also because they're feeling isolated. They don't feel like they've been entrenched in the culture of the organizations they're working with, and they want to go back to work and meet their peers in person and work collectively. There may be family issues that create extra stresses due to the pandemic and family dynamics. So somebody with a sick child or a sick spouse that they live with who may be immunocompromised, so they themselves may have issues and concerns about bringing infection home after going into the workplace. There may be other mental health factors along family dynamics that are involved. So it's important to be sensitive that those are out there on an individual case-by-case basis, and it may be prevalent. The other major factor to think about is kids going back to schools. I mentioned before, in Ontario, we already have 189 cases in the first week of positive cases, and that's leading to some school closures. I think there's been one case of that so far in Ontario. There's been some cohort isolation where kids are being sent home. And they'll have to isolate and quarantine and get tested. And it's important for employers to recognize that employees may have to be quite flexible on a day-by-day basis, particularly if they have kids who are going to school and daycare, and if they get sent home on a whim, they may not be able to arrange childcare. So the flexibility of allowing that employee to be able to take care of their children who have been put into isolation, or other circumstances around school closures, that will be really, really key and part of the flexibility strategy that I've referenced multiple times in this presentation. So when we think about going forward throughout the rest of this calendar year and into 2022, we know that the lessons learned in September to December will lay the foundation for a return to office strategy going forward, with many workplaces adopting a hybrid approach, but making their own considerations to land on how do we continue with hybrid work going forward beyond the pandemic. We know that masking indoors is probably going to be one of the last things to be lifted in terms of restrictions related to the pandemic, and we will probably continue to see a legacy of masking in indoor spaces and public spaces. I, in fact, can say myself, I think my practice has changed in that every winter season going forward, I will happily wear a mask when I'm seeing patients in clinic, because last year, even though I was seeing patients in person in full PPE, I was very excited that it was the first year I can remember in my professional life that I didn't catch a viral respiratory infection. And that was great. So I'd like to keep that. It's important to recognize that vaccines are effective at reducing infection and transmission and severe illness, but they don't necessarily stop transmission. So people who are using the thought process that I'm double vaccinated, so I'm okay. Remember, vaccines are one slice of Swiss cheese in the Swiss cheese model. We still need to adopt other measures in combination with vaccines to help keep our workforces protected from transmission. And lastly, the pandemic will be finished when the cases are zero and we're not seeing new case counts, and the ICUs are free to be used for people with other illnesses, people with traumas, and people who are post-surgical. And the healthcare system can try to start to catch up to all of the things that have been delayed. Thank you very much for allowing me to present.
Yes, thank you very much. Very insightful. At this point, I'll turn things over to Jeff, who's been monitoring for questions, and we can proceed to answer any of those.
One question here is any additional considerations on HEPA filters for closed buildings with unsupportive landlords? given concerns around aerosol transmission?
Yeah, so I think it's a very valid question. You know, the CDC has published some publicly available information, and so has ASHRAE, ASHRAE, which is an organization that has identified particulars for how to approach filtration and ventilation, even in terms of, you know, putting fans in workspaces and the direction of airflow. There's quite good data available out there publicly now. I would say when it comes to HEPA filters, it's fairly easy to institute portable HEPA filters that you can put in office spaces, even if there isn't the ideal filtration in the HVAC systems in a larger building, for example.
Okay, thank you. Next question. If a lockdown was necessary, again, do you think it would be as strict as the former ones? Ontario has had locked things down more than anywhere else in North America.
So I think our biggest risk right now is schools, and as workplaces go back, I think with the vaccination rates being higher than previous, I think that we are hopeful that the lockdowns, if there are any, we'll see measures being pulled back, but not necessarily full lockdowns in the same fashion. I can't comment for the government, but you get an idea as the case counts go up, what measures are being considered. And it always comes back to first principles. You know, we're really pushing to encourage those, you know, we won't convince people who are staunchly against vaccination to get vaccinated necessarily. But even within the medical community, we'll encourage individuals who are on the fence the benefits of getting vaccinated and how they outweigh the risks of getting vaccinated. And ultimately, as we see the numbers go higher with vaccination, we should see less risk of outbreaks, which leads to less risk of major lockdowns. The key message here is that everybody should consider that the pandemic is not over. And so we still need to be cautious. And it's unfortunate that getting your vaccine doesn't allow you to throw off the mask and host a party with 150 people right away. But again, we're moving in a certain direction to move past this. And as we continue to make those measures, the risk of lockdowns will become less and less.
Okay, thank you. Going back to one of your former slides, can you explain the difference between the two carditis?
Myocarditis is an inflammation of the muscle tissue of the heart, so the part that actually pumps the blood that's in the heart. Pericarditis is an inflammation of the lining around the heart tissue. They're very similar, but slightly different. They're treated in a similar fashion and hold similar risks. It's true that the vaccines can cause these as a side effect, although it's quite rare. The irony of it is that the illness of a COVID-19 infection can also cause inflammation. The most common cause of myocarditis is viral infection. So that's when people weigh the risk and benefit analysis of getting vaccines versus getting the infection.
Okay, next question. The AstraZeneca vaccine versus the Pfizer vaccine. Can you speak towards the mixing of the vaccines?
Yeah, so it's an extrapolation only, as this was only truly adopted in Canada to mix and match the vaccines. Although there are some small studies elsewhere with AstraZeneca and Pfizer specifically. I believe there's a Spanish study and a UK study that look at this. The protection lands somewhere in between when you have one dose of one and one dose of the other. The protection is quite good, but it's not perfect. It may not be exactly as high as 2 doses of the Pfizer vaccine against the Delta variant. A logistical issue that people have wondered about is in terms of future travel, because some parts of the world are accepting travelers who've had the AstraZeneca vaccine and others aren't. So I think that's something that our government's going to have to help us negotiate in terms of traveling or working with those other governments, or allowing a program where people who've had AstraZeneca doses, what they should do for future vaccination status.
Okay, thank you. Next question, how to deal with individuals who have not become vaccinated due to conspiracy theories or religious event arguments, etc. Can the number of these people prevent us from ever defeating COVID?
Well, I would certainly hope that the number of that wouldn't stop us from defeating COVID or getting past COVID. I think it's a difficult fight that we're having because this is a global thing. So another consideration when you think about defeating COVID globally is that there's other pockets of the world where people are significantly lower vaccination rates than us. And, for example, that's why the World Health Organization is encouraging Western countries to hold off on third doses or boosters and instead donate vaccine doses currently to other parts of the world where the vaccination rates are lower. I think if you look at, if you look at the Canadian population, nearly 80% of eligible people have had at least one dose of the COVID vaccine. Traditionally, we see for us to quash a viral infection that can spread through the community, you need about 85 to 90-ish% of the population vaccinated. And of course, I must say that we haven't seen a specific statistic or modeling suggestion for what percentage of Canadians would need to be vaccinated to quash COVID-19 in Canada. But I have seen one slide from the Public Health Agency of Canada. Pardon me, I'm just going to pull it up because I want to answer that independently. I believe it was about 85%. They were looking for at least 80% fully vaccinated coverage against all groups. And so that includes the groups that aren't currently eligible, including those under the age of 12, because you might see some confusing statistics sometimes where you see, well, it's 74%, but then it's 67%. And that's because you have to look at which group are we looking at. And we might be, close to 80% vaccinated of individuals who are eligible, 12 and above right now. But if we include the cohort of those under the age of 12, we might only actually be, closer to 70% fully vaccinated for individuals in our entire population. But the Canadian government is benchmarking 80% vaccination for the entire population.
Okay, and to go along with that, with your Swiss cheese model, Dr. Abrams, a comment from a participant was, thank you for reminding everyone that vaccines are they don't make you invulnerable, but part of a larger plan. And also the next question was, how much of an impact will vaccinating kids under the age of 12 have on any future waves, potential waves?
Well, I think this is the biggest scenario that's still unanswered, right? I think it's going to have a huge effect. It looks like Pfizer was submitting an application for authorization from the FDA for their vaccine for kids aged 5 to 11, or 5 to 11 years and 364 days, sometime this week or in the next week. And once we can vaccinate all the school-age children, school is one of the places where we want people to be back in school. We think when we weigh all the risks and benefits, it's important to keep measures to keep kids in school and have them learning in class with their peers and socializing with their peers, and not continue to do school through distance learning and on a screen like we are today. The issue is that we will continue to see case outbreaks in those cohorts until the majority of those kids are vaccinated.
Okay.
So vaccination of those kids will be the next big step at stopping future waves or bumps, or however you'd want to describe them, as hopefully with each uptick in cases, we might see a reduction in the peaks, and therefore lesser need for locking down our communities to fight back.
Yes, we do have a little bit of ways to go, I think. Next question. How long do you expect to take to clear the backlog of delayed healthcare procedures in the hospitals?
Years. We had a backlog before COVID, right? The resources that were there, we see, elective surgeries, joint replacements, cancer surgeries, cancer screening. There were wait times, right? It takes even here in Toronto, which we see some of the most concentrated healthcare. It takes months to get appointments with specialists for initial consultations, let alone getting procedures done. We know that there were quotas on things like quotas on funding for procedures like elective joint replacements. And now with the cancellation of surgeries and postponement of surgeries, we're going to see a huge backlog. And we'll see also the increase in acuity of certain cases. So for example, cancer-related screening and surgeries that will have to play catch up will come before other procedures, and so there will be a triaging system in place. It won't necessarily become first come, first serve, like most other ways in which we apply principles to medical triage.
Okay. John, do you have anything to comment on the local area?
No, just to echo what Dr. Abrams said, and that's what we're hearing. And all I can say is our leadership does have a plan. The details of that plan, obviously vary by, surgery type and whatnot. But no, for a few months now, they've already been trying to figure out how we're going to overcome the backlog, which, as you said, precipitated from a backlog. So there's a plan in place, but it will take some time.
Not to get into the politics, but I hear that healthcare might be a hot topic on the federal campaign trail right now.
Okay, another question that came in. Do you know of any scenarios where public health outweigh the individual choices, which is the legal debate for non-essential offices being able to institute a vaccine mandate? Or where can someone look for that information?
I think you'd have to, I'm going to pass on answering that question because it's not in the area of my expertise. I think you'd have to contact a legal expert in the field.
And what is Health Canada's position on the annual COVID-19 vaccines?
It's a great question. We've been hearing a lot of rumors about potentially needing annual vaccination against SARS-CoV-2. There is no official position yet from Health Canada on the future of COVID vaccines because it's still being studied.
One more question. Do you expect that the COVID vaccine will need to be altered each year like the flu vaccine to address the mutations?
There is a significant possibility that we may see continued escape variants, and as a result, the vaccine may need to be re-administered or slightly modified and re-administered on a regular basis in the future. I think just there's not enough data to be able to really make that decision at this point, although there are suspicions that that would be possible.
So we have some resources available for you as well. Family Services Windsor-Essex. If you wish to get in touch with Medcan or Dr. Abrams, it's medcan, medcan.com. We have various other local resources available. Family Services, the EAP, wechu.org, OCOW as well, Occupational Health Clinics for Ontario Workers with their local office, and CMHA, the Windsor-Essex County branch. Okay, so with that said, thank you very much to everyone. Thank you very much for attending, and have a great day.